Good morning, everyone. Thank you so much for having me today. I'm really excited to talk to y'all about freezing and burning kidney cancer. So just to kind of go over what I'm planning to talk about today, I'm going to introduce interventional radiology. Most kidney cancer patients have met a surgeon, and most kidney cancer patients have met a medical oncologist. But not every kidney cancer patient is going to meet an interventional radiologist. So I just kind of want to tell y'all kind of who I am, what I do. We'll discuss briefly the staging of kidney cancers, go over the types of ablation and the pros and cons of each one, talk about if you would get an ablation, what that IR clinic visit looks like, what the procedure date looks like, how we follow up those patients, and then some case examples. Okay, so an interventional radiologist uses imaging guidance to perform procedures. We use all kinds of imaging guidance. We use ultrasound, we use CT, we use X-ray. We do a lot of image-guided biopsies, including kidney cancers. We also place ports, do venous access for patients that need chemotherapy. We do angiography. What angiography is we go into a blood vessel, we take pictures with contrast in real time under X-ray. And we can use that to guide us. We can stop bleeding that way. We can also treat cancers that way. But what I'm going to talk to you about today is ablation. So similar to most physicians, I went to 4 years of undergraduate, 4 years of medical school, and I did a 1-year internship. What made me an interventional radiologist is I did a 5-year residency of diagnostic and interventional radiology, where I learned how to look at images, but also do image-guided procedures, and then a 1-year fellowship that focused specifically on those image-guided procedures. So I know we went over kidney cancer staging already with Dr. Arcott. I'm going to focus in on these T1A lesions. And so those are lesions that are confined to the kidney and are less than 4 centimeters. This is the vast majority of patients that are treated with ablation. Every once in a while, we will also treat a T1B lesion, which is also confined to the kidney, but a little bit larger than 4 centimeters. But the majority of our data is treating these T1A lesions. So who should consider renal mass ablation? Small renal masses, right, T1A lesions, patients that may not be the best surgical candidate. This is less invasive than surgery, and so if there are a lot of other comorbidities, that kind of may push a patient towards considering ablation. Patients that don't have good renal function at baseline, we can also help to minimize the loss of normal kidney tissue to help try to preserve that kidney function. And then some patients just don't want surgery. And if they're candidates, they can come to us and we can help treat those cancers. This is kind of just, I'm not going to go through all of it, but some of the society recommendations on who should be considered for renal mass ablation. So what is ablation? We're destroying cancer cells. We're denaturing the proteins, which means we're breaking up the proteins, and then we're causing necrosis within the tumor. I'm going to focus on 2 types of ablation, which is what I use in my practice the most. Historically, radiofrequency ablation, we have some older data for that, but the newer data kind of tends to show a benefit, more of a benefit from microwave ablation and cryoablation. So those are the 2 that I'll be talking about today. So cryoablation uses pressurized argon gas to decrease the temperature of these probes that we put into the renal cancer. We can get them as cold as 160 degrees Celsius, but really we only need to get to about -20 to -40 degrees Celsius to kill the cancer cells. What it does is it causes ice crystals to form both inside and outside of those cancer cells. And we do something where we freeze it, so we drop the temperature down for 10 minutes typically, then we let it thaw, so we turn off the ice. And actually the thawing is what kills the cancer cells. And we usually do 2 rounds of each, so it's 10 minutes of freezing, 8 minutes of thawing, 10 minutes of freezing, 8 minutes of thawing. And what that does, it causes cellular dehydration. It causes the blood vessels going there to thrombose or shut down. And it causes the membrane of those cells to rupture, and it kills the cells. The nice thing, one of the main pros of cryoablation, they freeze in a very easy to predict fashion, and you can see the ice ball that's formed on imaging. So we do CT scans during the procedure to make sure that our ice ball is the size that we want and that it's not going anywhere we don't want it to go. There is a slightly higher risk of bleeding with cryoablation compared to microwave ablation. That is one of the cons of this. Also, they don't treat as large of an area as the microwave probes do, so sometimes we do need to use multiple probes, and if you think about it, if we're sticking more needles in, we can cause more bleeding that way as well. Very good recurrent-free survival, 87 to 98%, 5 to 10 years after these treatments. And this picture here just shows all the different types of probes that we can use, and then the bottom right just shows what that ice ball kind of looks like if you were to freeze it, kind of holding it in the air. Microwave ablation, this is the same technology that you use in your house with your microwave. So what it does is there's this antenna, this probe, sends out electromagnetic waves. It causes the molecules in the cell to kind of move and vibrate, and then they heat up. And so they can get as high as 100 Celsius degrees. It causes protein denaturation again, and that's what leads to cell death. It's less affected by heat sink than radiofrequency ablation. And heat sink, think about it as if you've got a match right next to the Mississippi River. So if there's a big blood vessel that's flowing really, really fast right next to what we're trying to heat up, it takes away that heat. And that affects how well you ablate that area. And so microwave, like I said, less affected by that than radiofrequency, which is why we have moved towards microwave compared to radiofrequency ablation. The procedure times are a lot faster. We don't have to thaw it, right? There's no ice ball. So those procedures usually go quicker. They also have excellent disease-free survival. Complications. I think this is the most important thing to know. I try to spend the most time talking to patients about all the things that can go wrong. Hopefully, we don't ever have to worry about it, but I want my patients to be well informed about what could happen that we don't want to happen. So complications rates of 3 to 15%, I just pulled a couple review articles to get these numbers. It's pretty similar for cryoablation and microwave ablation. Bleeding is the most common complication. I am putting a giant needle through your back into the kidney. The kidney's got a lot of blood vessels. Most of the time, it's just a little bit of oozing at the site and we don't have to do anything. Sometimes it is serious bleeding that requires blood transfusions, additional procedures, overnight admission. The other thing I like to talk to patients about, there is a risk of damaging structures that are next to the kidney that we're trying. So if it's up at the top of the kidney, we can damage the lung, cause a collapsed lung. The bowel often will sit right next to the kidney. The ureter, which is the part that drains the urine from the kidney into the bladder. And then we also want to make sure that we're not causing any damage to the skin itself. So before an ablation, every patient that comes to us has an IR clinic visit where they meet either our nurse practitioner or physician assistant. They go over medical history, including your medical problems, the anticoagulation medicines that the patient is receiving. We go over the imaging, we talk about the procedure, all the risks, all the benefits, what follow-up looks like, and then we schedule the procedure. When patients come in for procedure day, they check in, they get an IV, we go over labs, we make sure their vitals look okay, they meet the anesthesia team, and they sign all the consents. We do all of these procedures with general anesthesia, so tube down the throat. Most patients are laying on their belly for the procedure because, as you remember, the kidneys are in the back. That's how we're going to get there. Hydrodissection we'll put a tiny needle between where we're going to burn or freeze and something we don't want to burn or freeze, most commonly the bowel. And we can just inject some saline and kind of push it away. That decreases the risk of damaging structures next to where we're going. We can perform a biopsy at the same time. Pathology comes down and takes a look at our samples to make sure that we've got enough tissue if we are going to do the biopsy. We do our freezing or burning. We take the probe out. We scan the patient, make sure everything looks okay, and then they go to the recovery area for 4 hours. The vast majority of patients go home after that 4-hour period. If there are any complications, it may require an overnight stay. Follow-up, like I said, most patients go home with antibiotics, pain medicine, and nausea medicine. We often get either an MRI or a CT 4 to 6 weeks after, bring you back to clinic, take a look at everything. Most of the time, that's it. We just get you scheduled for follow-up. Sometimes if there's a little bit of that mass that's left, we'll schedule for a repeat ablation just to touch up any areas that were missed. Usually we do repeat imaging every 3 to 6 months to that 1-year mark, and then those patients usually follow up with just urology after that. Local recurrence rates, which means when the cancer comes back in the area that we treated, they've decreased over the years as our technical expertise has improved with these procedures. And recent studies have shown no significant statistical difference between local recurrence rates between partial nephrectomy and ablation. So as a radiologist, I would be remiss not to show you some pictures, right? So this is a CT. You can see right and left, so this patient's on his back right now. There's our mass. Now for the procedure itself, we lay him on his belly. So it's flip-flopped. This is my cryoablation probe, which is skewering the mass like a shish kebab. And then we got a nice ice ball there, as you can see. And so this is his follow-up, so he's back on his back. And as you can see, what we were talking, I think Dr. Arcott was talking about earlier, we're looking for enhancement. There's no enhancement in that mass, so this is a great result. This is an MRI. This is just a normal section of the kidneys, just so you can see what they look like normally. And then here's that mass we don't like. Here's a coronal image, so it's almost like you're looking at the patient face on. And we chose to do microwave ablation here. Like I said, cryoablation, the risk of bleeding is a little bit higher. This patient couldn't come off all of their anticoagulation medicine due to some of their heart problems. So the risk of bleeding was going to be a little bit higher for this patient. That's why I chose to do microwave ablation in this case. You can see my probe again, skewering the mass like a shish kebab. And then during the procedure, as we're burning, gas molecules form. I don't know how well it projects, which is why I kind of drew all around, but you can really see during the procedure, where you're burning, but the gas can also go a little bit past that, and it doesn't mean you're burning in that area. So this kind of just shows that the ice ball is a lot easier to see on imaging, and so that's why the cryoablation, sometimes it's easier, but you still get a good idea with microwave ablation where you're burning. This is right after we took the probe out. No evidence of bleeding. You can see there's a little bit of hyperdensity, which means it's kind of brighter white in the mass itself. There may be a little bleeding in the mass. That is okay. We don't want bleeding outside of the kidney. And then there's a little bit of gas left over. Totally fine. And then we got an MRI afterward, and as you can see, there's no enhancement on that mass. So that is exactly what we like to see.